Good afternoon, friends. My talk is on full endoscopic lumbar discectomy, and I will be briefly talking on both transforaminal and interlaminar approach. Full endoscopic operations can be considered as one of the most sophisticated and highly evolved forms of minimally invasive spine surgeries. As we all know, there are two basic approaches, transforaminal and interlaminar, and both these approaches they work hand in hand with each other to cover the entire spectrum of diseases. There is no one single approach which is able to tackle all kinds of pathologies. Although interlaminar approach has been described much later, over the years it has become a dominant partner because of the variety of indications it is able to tackle. So as to consider the indications for transforaminal approach are limited to 30% of the total pathologies, whereas interlaminar approach, because of its versatility, is able to tackle nearly 70% of all the kinds of pathologies. So indication wise, transforaminal approach is more suitable for foraminal or extraforaminal disc herniations, low migrated, central or broad based herniations. It is also a preferred approach at upper lumbar levels or thoracic level disc herniations. Whereas interlaminar approach is more suitable for lower lumbar disc herniations, especially L5S1 disc herniations, where transforaminal approach is not possible. It is also very effective in dealing with high grade migrations and in patients with herniations associated with stenosis. It is also a preferred approach for cervical disc herniations. Now let's talk about the transformal approach first. First case, non-migrated L4-5 left paracentral herniation. Now this is the clinical video showing the entry of the endoscope. We mark the skin entry point for the needle. The needle is inserted once the position is confirmed. The stylet is removed and the guide wire is inserted through the needle. The dilator is passed over the guide wire, and once the position is confirmed, the working channel is then inserted over the dilator and hammered inside the annulus to anchor it. And this is the final position of the working channel, and finally the endoscope is passed through the working channel. Once the endoscope is inserted, we first differentiate the tissue structures with the radiofrequency cautery. That's the ventral epidural space. We start cutting the posterior annulus to expose the disc herniation. That's the disc herniation you see there. And once it is released adequately, then we remove it with the help of a disc forceps. And that's the ventral epidural space which is being probed with the radiofrequency probe, and the well decompressed nerve root at the top. And this is the actual clinical picture showing the removal of the disc herniated fragment. These are the post-operative MRI pictures showing a well decompressed nerve root and complete removal of the disc herniation. And all this has been done through a very small incision which is less than 1 centimeter. Another case, an up-migrated foraminal disc herniation at L4-5 level on the right side. Here, to protect the exiting nerve root, we place the working channel on the lower pedicle. We identify the pedicle first, then we identify the surface of the disc. Then we gradually shift the working channel upwards to retract the exiting nerve root and identify the up-migrated disc herniation. So this is the clinical video. This is the pedicle which is being palpated, and that's the disc surface. Now the cannula is rotated and the exiting nerve root is being retracted, which is at 3 o'clock position. This is a dissection to expose the migrated disc herniation. The annulus is being cut, and that's the disc herniation which is being removed. And that is the traversing nerve root which is well decompressed, and you can see it pulsating. And as you withdraw the working channel, you can see the exiting nerve root there. So this is a very minimally invasive procedure where we are not even damaging the ligamentum flavum. These are the post-operative MRI pictures showing a completely removed foraminal disc herniated fragment and a well decompressed nerve root. Now coming to the second technique, which is the interlaminar approach, which is familiar to most of the spine surgeons. The surgical technique begins with the docking of the working sleeve or the cannula. For this, you have to identify the center of the interlaminar space, and an 8 millimeter incision is taken through which the dilator is inserted till it reaches the facet joint level. Once the position is confirmed, the working sleeve is then slided over the dilator and the final check position is confirmed, and this completes the docking process of the working channel. Once the cannula is in position, the surgical technique differs depending on the size of the interlaminar window. There are two possibilities. If the interlaminar window is very wide, where the nerve root, the traversing nerve root is not covered by the facet joint, in this case, we do not have to resect any bone. So we just make a small slit in the ligamentum flavum through which the hernia can be removed. Whereas if the interlaminar window is narrow and the traversing nerve root is lying under the facet joint, some amount of bone drilling is necessary. We resect a medial part of the facet so as to uncover the nerve root, after which the hernia can be removed effectively. So here is a case example. The first case, wide interlaminar window, you see a large extruded disc herniation at L5S1 level on the right side. It is an axillary disc where you can see the nerve root is not covered under the facet joint. So we can just make a small slit in the ligamentum flavum without any bone resection and remove the herniation effectively. Now coming to the actual surgical procedure, the endoscope is then inserted through the working channel, and this is the first vision. We see some muscle and adipose tissue which is removed with the help of forceps to expose the ligamentum flavum. We start cutting the flavum near the midline layer by layer till the epidural space is opened, and the tip of the cannula is used to stretch the ligamentum flavum so that it becomes taut and the cutting becomes easier. And once the space is opened, we start cutting the flavum laterally till we reach the facet joint. So this is the last part of the flavum which is being cut. Once the flavum is cut, then the next and the most important step is to identify the lateral border of the nerve root. The nerve root is slightly mobilized to confirm, and since this is an axillary disc herniation, we do not retract the nerve root too much medially. We directly go towards the axilla and visualize the herniated mass. The annular release is done with the help of a dura dissector and an annular cutter, and the herniation just pops out. Multiple herniated fragments can be removed under direct vision. And this is the final complete removal of the hernia mass. The 25 degrees angled endoscope allows us to look under the dura and the nerve root also. And you can see that the entire surgery has been done through a small slit of 2.5 millimeters wide and 1 centimeter long. So this is a clinical video showing the removal of the large herniated mass through the endoscope. And these are the final post-operative MRI pictures showing complete removal of the herniated mass. And you can see that the muscles are all preserved and there is hardly any damage which is visualized in the ligamentum flavum also. Now consider the second case scenario of a narrow interlaminar window. This is an up-migrated L4-5 disc herniation with a discal cyst, and you can see the interlaminar space is very narrow. So in this case, we will be doing bone drilling. Now this is a right-sided approach. The technique is very similar. Once the endoscope is inserted, some muscle fibers have to be removed to expose the ligamentum flavum. We identify the facet joint and we release the superficial part of the flavum which is attached to the medial margin of the facet. The tip of the descending facet is identified like this, and drilling is started from the tip of the descending facet continued upwards. This is the drilling of the ascending facet. The aim is to widen the interlaminar window. Then after bone drilling is completed, we start cutting the ligamentum flavum layer by layer to open up the epidural space like before. And we continue cutting the flavum laterally towards the facet joint till the lateral border of the nerve root is identified. So that's the nerve root. We mobilize the nerve root and we advance the tip of the cannula downward towards the base and we rotate it so as to retract the nerve root with the tip of the working sleeve. So it acts like a dura dissector. The cannula is then tilted upwards to visualize the discal cyst, and this is the annular release which is being done to mobilize the herniated mass, which can be easily removed with the help of a forceps. So there you see there is an exiting nerve root there. That's the axil of the exiting nerve root, and this is the well decompressed traversing nerve root. See, these are the post-operative MRI pictures showing complete removal of the disc herniation through a very small incision. And all of this has been done through a 8 millimeter incision. There is hardly any blood loss, and we never insert a drain inside. This is another case example, a high up migrated disc seen on the left side. This is a left-sided approach, and there you see the lateral border of the nerve root is identified. The nerve root is then retracted with the tip of the working sleeve, and you can see part of the herniation being removed there. The PLL is then released to visualize the up migrated fragment which is lying under the nerve root, and you can easily visualize the 25 degrees angled endoscope allows you to look under the ligamentum flavum and under the nerve root, and this is complete removal of the herniated fragment. These are the post-operative MRI pictures showing complete removal of the high migrated disc herniation. Now sometimes we use special approaches. For example, this is a case of a right-sided foraminal disc at L5S1 level, causing severe pain and weakness in the dorsiflexion of the great toe. The conventional transformal approach in this patient is not possible because of high iliac crest, and there is a chance of injury to the exiting nerve root as it is pushed backwards by the foraminal disc. Interlaminar approach obviously cannot reach the foramen of the ipsilateral side. So what are the other options? We have transiliac approach, which is too much invasive. So we contemplated for a contralateral interlaminar approach in this case. So we approach from the left-sided interlaminar space. We drill the base of the spinous process and the superior lamina in the midline to access the contralateral ligamentum flavum. The contralateral ligamentum flavum is completely removed. That's the lower opposite pedicle, S1 pedicle, and that's the opposite sided traversing nerve root. This is the facet joint, L5S1 facet joint. We start drilling the non-articular part of the facet joint. That's the exiting nerve root or the L5 nerve root of the opposite side. And this is the foramen there. We cut the annulus to release the disc herniation. And that's the disc herniation which is being removed. Further probing is done to identify any remnant fragments. This is drilling of the osteophyte there, and there you can see the exiting nerve root has been completely mobilized. That's the exiting nerve root, the traversing nerve root. This is the dura, and this is the intact ipsilateral ligamentum flavum. So you can see the post-operatively there is complete removal of the foraminal disc herniation and well decompressed nerve root. And if you look at this CT scan, you can see a small hole in the opposite interlaminar space at the base of the spinous process and just at the superior lamina. Very minimal invasion of the spine. So to summarize, there are numerous advantages of endoscope over the microscope, and one of the biggest advantage is the presence of irrigation fluid channel. The irrigation fluid, it washes out all the debris and the blood clots to maintain a clear field of vision. Another advantage of endoscope is endoscopy allows the possibilities to choose a need-based approach. There are multiple approaches described in endoscopy depending on the location of the target and the pathology. And the purpose of all this is to minimize the access-related injury, both bony and soft tissue, and ultimately to avoid fusion. So finally, the take-home message, full endoscopy is a very sophisticated and highly evolved form of minimal invasive spine surgery. It offers trifold benefit as compared to bifold benefit of microscope, where we not only have illumination magnification, but we also have a very clear field of vision due to irrigation. And because of the possibilities of various approaches or target specific approaches, it really minimizes access related injuries and ultimately helps in avoiding fusion. And it is an excellent procedure for difficult to access areas, especially in the thoracic and the cervical spine. Thank you.